society and from the...
It's never a one-man show, so it's always a team effort. To everyone at Dhami Eye Care, Ludhiana Ophthalmic Society, and especially Dr. Nitin Batra and his team, it would not have been possible without everyone that we've put up this beautiful program. So we now begin our first session, Insight into Imaging. We've tried to divide the whole, this academic program into two kind of things. One is a didactic lecture, which I have called a class, and next is a more interactive session, which is the live wire. So although we tried to make it very interactive, but we just made sure that the live wire sessions are very interactive. So the first class that Dr. Sahil GOEL is going to take for us is Nuances of Pentacam Imaging. He is an excellent academician, and he is literally like the walking textbook for us. And he was earlier at Dayanand Medical College, and he's now started his own private practice, and a very good neighbor that we have. So welcome Dr. Sahil on stage, and he's going to be talking about Nuances of Pentacam Imaging. The panelists, I request Dr. Dhami, Dr. Rajesh Sinha, Dr. Tushe Om Prakash, Dr. Randhava, and
both anterior and posterior float or curvature of the cornea. Various other devices, including dual chamber, have come up, especially CS and LED, which are also being used, but nothing matches the ease and convenience of Pentacam, probably because of its very rosy display. No matter what machine, no matter what index we are using to detect keratoconus, the basic thumb rule is still age rule. 1999, 25 years back, this was given that by Reverend and McDonald that inferior superior asymmetry of more than 1.4 diameter is suggestive of keratoconus. Multiple other indices, Meda bias, PSI index came into being, but I think till date, when we are looking at keratoconus and any asymmetry in the cornea, the inferior superior asymmetry and central K more than 47.2 are still the two basic colors for detection of keratoconus. Yes, we have evolved from curvature to thickness and posterior elevation also. Most of the tomographers give a cutoff of 15 to 20 microns on posterior float as a cutoff, and thickness less than 500 as a yellow flag and suppose that is a red flag. In this particular map, if you see, the superior curvature is 43.5, inferior is 44.2. Even though asymmetry is not significant, just the color makes it look like that inferior is steeper than the superior. So do not just go by the colors, because various tomographers will have different color coding. Our eyes are become used to seeing a particular color coding, and that's why we find changing to a different tomographer sometimes difficult. Actually, if you train your eyes to specifically look at the numbers, you will not find comparing various tomographers difficult. What Pentacam basically did, probably why I feel it became so prevalent, was this variant visual display, in which they changed the reference sphere by excluding the center 3.5 mm zone and including rest of the peripheral cornea for calculation of best fit sphere. Now with this new best fit sphere as reference, when they try to calculate the elevation points, this center part, which was otherwise ectatic, which would have shown the elevation of just this from the yellow line to this elevation increases. This is what Belen does. Both front and back surface, it calculates the elevation from the natural reference surface. Then it calculates, if you see carefully here, this is excluding 3.5 mm zone. I'm not sure if it cannot be seen on the screen. But this calculates the reference surface by excluding the center 3.5 mm zone, centered on the thinnest point. And the difference between the two elevation maps is finally what it calculates. And using its own AI-generated algorithm that has come up with these cutoffs of 5 to 7 microns and more than 7 microns. So this is the deviation of front surface, this is the deviation of back surface. These are two first things that variant Mendoza looks at. Now when we start looking at variant Mendoza, a lot of times we just look at individual D. This is D front, this is D back. This is specularity correlation index, this is the D, that's the thinnest point, and this is decentration of the thinnest point. Individual D have a very poor sensitivity and specificity, as can be seen here. Now, sensitivity and specificity to a lot of us of 70 to 80% might seem like a really good number, but clinically what is relevant is positive predictive value. With a prevalence of around 5%, if you really calculate the positive predictive value of these numbers, comes out to be hardly 20 or 30%. That means individually positive, yellow or red means that the probability of having keratoconus is less than 30%. 30% is too minuscule to be significant. So please stop considering a Beren-Ambrosio of individually of yellow or red as significant, because 70% that is not keratoconus. If you go to overall D, where specificity increases to 95% and sensitivity to 85%, because of high specificity, the negative predictive value is around 95%, which is a very good number. That means if overall D is white, most likely it is not keratoconus, and that is where it's used like in refractive surgery screening. When you are looking at overall D, if you see white, most likely it is not easier. But if it is red or yellow, the sensitivity is poor at 85%, which means only 60 or 70% of overall D, yellow or red, would actually turn out to be ectatic cornea. So you have to go back to the basics, you have to go back to the quad map and not interpret keratoconus or atresia just looking at the index, just looking at the Beren-Ambrosio split. This is one example where overall D shows to be 2.69. The central cornea is normal, everything looks good. Even the curvature map as I showed was normal. This was the curvature map of the same patient. If someone looks at the overall D here and saying that this is red, which means that this is not fit for refractive surgery, I would disagree, because the sensitivity or cost predictive value of this red is less than 30%. Overall D is white, you can see the quad map, it shows normal, and that is how your final judgment should be, not based on an index, but based on the quad map on the raw data. With this, I would like to come to another aspect. While interpreting keratoconus, another thing which is important traditionally which has been taught is that the thinnest point and highest elevation of posterior surface, if they coincide, that is for the suggestive of keratoconus. Now with Pentacam, we had been looking at this, that the steepest Kmax, the thinnest point and posterior elevation highest, if they overlap, that means the cornea is most likely ectatic over there. We were using epithelial thickness maps earlier, but unfortunately with Shinker-based devices, epithelial thickness maps cannot be included in the same device. They cannot simply calculate the epithelial thickness. For that, we were using dosity. The limitation of most of the anti-segment dosities that we have been using is that the resolution is in the range of 3 to 5 microns, which makes the repeatability of epithelial thickness mapping with these equipments not very good. 2017 is when, for the first time, I gave a thesis to my resident to evaluate the sensitivity and specificity of epithelial thickness profile in detecting keratoconus. It turned out to be 70 to 80%, and that's when we realized that the repeatability of Zeiss HD OCT is not great at detecting epithelial thickness profile. But what I realized over the last 6 months is with NDV on that, resolution has come down to 1 micron, and the repeatability of epithelial thickness has really improved, which makes the utility of epithelial thickness mapping in detecting keratoconus even great. So there is no data comparison yet, but if you look here, this is where the cornea is maximum ectatic or bulging. This is where the epithelium is the thinnest, 36 microns compared to 46 microns everywhere outside. So what ectasia we are seeing over here has been significantly masked by a thinner epithelium in the area of bulging. The ectasia at the stone or the bone membrane is already more than what can be visualized over here. So this masking is important to unmask. I'll show this. Okay, this is one scoring system that Andiron has come up with. I don't really use it. It is not as great as Beren-Ambrosio display yet, but they are trying to improve. One interesting case I would like to show. This is topography of a 35-year-old post-LASIK patient. If you look at it, the visual acuity is 6.6, no refractive error. A lot of us would pass it saying that this is a normal topography. Now look at the actual scan. Again, you would see, yes, there is thin cornea. Yes, the posterior elevation is within normal limits, but this again is not really suggestive of keratoconus. But if you look at epithelial thickness profile, you would see in this area compared to the 55 or 50 average thickness elsewhere, this is only 44. So there is a 5 micron thinning in the epithelium over here, which is not being reciprocated in any other map. Normally, I would have neglected this. But the beauty lies in the fellow eye. This fellow eye of the same patient already has a manifest post-LASIK ectasia. As you can see, central thinning, posterior elevation, and in the same area, significant thinning in the epithelium. So it's not in every patient epithelium would be able to diagnose this, but at least this one patient where there is post-LASIK ectasia in one eye and another eye is absolutely normal, you can see the epithelium trying to unmask the early aphasia in this eye, which goes on to say that this eye also has started to develop aphasia, and whether to cross-link it right away or wait for it to progress or manifest on the anterior surface is something debatable, but at least there is no doubt that this cornea has also started to bulge a little or is in early stages of aphasia. With this, I would like to end the talk. Thank you so much.
Thank you, Sahil. That was a very good presentation, and you stuck to some very important points. And one message that you gave was very important, that just by one reading on the Pentacam map, it doesn't help, because bad may show, even overall D can be a little suspicious in the yellow zone or so, but then you have to see other things like what is the pachymetric progression index, and that also is an important thing. Like if it's more than 1.2, then it is suspicious. If it's more than 1.6, then it is highly suggestive. Similarly, a brochure relational thickness, the ART max, that is again an important aspect. So instead of going for
All right. So.